Good afternoon, everybody. Thank you for having us to enjoy your beautiful afternoon together. I'm Sohaini from Kuala Lumpur, and let me have the pleasure of thanking Edward Life Sciences for their commitment and hosting this important event for us to share knowledge and experience, especially in the area of cardiac patients and its associated issues. This program today is called Perfusion Optimization for Cardiac Surgical Population Program. And I'm delighted to be informed that there has been over 250 registered participants for this event this afternoon. Thank you again, everybody, for your kind support. There have been strong support from India, Malaysia, Indonesia, and Vietnam. And there's also support that we receive from Brunei, Nepal, Philippines, Singapore, as well as Thailand. So please do sit back, have a cup of coffee, and enjoy the rest of the program. This program is designed with the objective to explain differences in perioperative hemodynamic monitoring, its management, and goals in cardiac surgery. It is also to establish a dedicated group of clinicians that is interested in promoting education and the incorporation of advanced hemodynamic principles into their clinical practices. This is also to serve as a fundamental for the subsequent clinical advancement in hemodynamic monitoring. To achieve this stated objective, we are going to implement 3 learning methodologies. First, the live engagement sessions with the faculty members via the webinar series, like what we're having today, whereby the invited faculty will share their practical knowledge that is important for any practicing clinician. Second, this knowledge sharing session via the webinar series will be further strengthened by the several selected video on demand series that will be provided via a link. In addition, a platform for networking will be provided to allow participants to interact and sharing each other real cases scenario with the faculty member. The program is prepared to be delivered over 6 months duration and will be staged into 3 levels. The first level is fundamental. It consists of 1 live webinar and supported by 4 video on demand. The second level is intermediate. It will be supported by 4 live webinar and supported by 9 video on demand. The last, which is the quality improvement achiever level, will be supported by 1 live webinar session. I am honored to be invited as the faculty member, and I would like to thank also Dr. Kanchi from Narayana Hospital, India, that has been kind to join me as the faculty to ensure the success of this program. As mentioned, this program will be executed over the next 6 months. This is a glance into the important dates that has been selected. I'm sure the host, Edward Life Sciences, will keep you updated on the highlighted dates and events. For the months of August, we have cardiac patients undergoing non-cardiac surgery. On October, we will have a perfusion optimization for cardiac surgery patient. On November, we will have TEE in cardiac surgery and mechanical circulatory assist device for failing heart. On December, we will have clinical case discussion. On January, we will have the new horizon in hemodynamic monitoring. And on February, we will have the quality improvement in cardiac surgery. These are the list of the video on demands. I'm sure the list will be provided later on. And For today, let us start with our first webinar, which is titled Perioperative Cardiovascular Evaluation and Hemodynamic Management of Cardiac Patient Undergoing Non-Cardiac Surgery. I will be the first speaker, and subsequent lecture will be provided by Dr. Kanchi. Worldwide, annually, there will be more than 200 million major non-cardiac surgical procedures, of which 1 in every 4 cases that undergoing non-cardiac surgery has a non-cardiovascular diseases. In addition to that, 1 in 20 will suffer myocardial injury, infarction, or cardiac arrest and death within 30 days of the operation. This perioperative cardiac complication after non-cardiac surgery account for 1/3 of perioperative death, substantial morbidity, prolonged hospitalization, increased cost, and it affects prognosis. How do we approach this then? Instead of base our clinical decision making on the conservative cohort database, such as the Framingham model, we should then tailor our clinical decision on how to provide precision medicine. The evidence should be collected based on the population-based management using the large-scale database analysis. And this is what being done by the group of clinicians that has issued a statement on the guideline from the Canadian Cardiovascular Society in 2017. In this new guideline, there is a huge paradigm shift where there is a lot of emphasis on the biomarkers, emphasis on the perioperative monitoring of patient at risk, and aggressive management of cardiac complication. To look at a glance on the Canadian guideline, basically, if you have a patient that have history of cardiovascular diseases coming to your operating theater, you should then decide whether the surgery is emergency or elective. Under the emergency situation, nothing much that you can do, you have to proceed for the surgery. But then you are requested to monitor this patient with troponin for the next 72 hours and decide your subsequent management based on the troponin results. For the purpose of elective surgery, you need to do the assessment of the perioperative cardiac risk stratification. And if there is a significant risk, you have to do the pro-BNP. If the pro-BNP is high, you need to proceed with the troponin T measurement for the next 72 hours after the operation. If the pro-BNP is low, then you can discharge this patient back to their home. But this guideline only gives us the guidance on how to manage the patient during the perioperative period. Nothing much is being mentioned on the intraoperative management, and leave us clinicians in a vacuum, trying to understand how should we address a cardiac patient undergoing non-cardiac surgery. And therefore, it is my aim to touch a specific patient condition of cardiac patient undergoing non-cardiac surgery, to give an overview and to discuss the potential hemodynamic goals that we should achieve while managing this cardiac patient undergoing non-cardiac surgery. For those who have done a lot of cardiac surgery, especially the anesthesiologists, I'm sure the extensiveness of the coverage couldn't be covered within the next 20 minutes. Maybe for the next 20 years, we will still be gathering knowledge and information to help us in managing cardiac patients undergoing non-cardiac surgery. But what I'm trying to do here is to simplify the perspective of the overview and the hemodynamic goals by A, B, C. What is A? A is etiology. What is B? B is how bad is the disease. And what is C? C is if the disease has any other complication that we should be concerned. So let us first with the coronary artery disease. Cardiac morbidity during or after non-cardiac surgery on patients with coronary artery disease is significantly associated with morbidity and mortality. It could be presented by an elevation of cardiac biomarkers, or the patient could have a typical sign and symptoms of ischemia. There is a strong association between the cardiovascular event with MACE after non-cardiac surgery, and therefore the time of surgery is important. The longer the time of surgery between the last cardiac event, the higher the chance that this patient might survive the surgery. Symptoms is important. Symptomatic patient, we should then advise this patient to go for PCI. But in the case of emergency, then we have to decide on how to manage this patient in our operating theater. The hemodynamic goal here is to maintain an optimum coronary perfusion, especially during diastole. A, we need to understand what is the etiology of the coronary artery disease. Is this familial? Is this something that has been going on for the past 20 years? Or this is something that is recent? How bad is the lesion? Is it 95% occlusion? Or is it only mild disease? Does this involve all three coronary vessels, including the left mainstem? Or is only involved on one distal non-significant branch of the arteries? What is the complication from the coronary artery disease? Does this patient is having ischemic cardiomyopathy with a poor ejection fraction? All this information is important for us to know while managing this patient going for non-cardiac surgery. The other situation that we are commonly facing is the heart failure coming for non-cardiac surgery. Again, from the extensive study involving more than over 200 patients undergoing elective and emergency surgical procedure, heart failure is significantly associated with higher mortality and morbidity. When we want to understand heart failure, again, we need to understand the etiology of the heart failure. What caused the heart failure? Is it ischemic in nature? Is it dilated cardiomyopathy in nature? Does it only involve the left? Does it involve the right? Does it only confine to the systolic heart failure? Or there's also a component of diastolic dysfunction that is affecting our patient? How bad is the heart failure? Managing patient with ejection fraction of 40% might be different from managing patient that have only ejection fraction of 10%. A patient with left ventricular size of 4.5 centimeter is definitely differently managed from those patients who has a left ventricular dimension in diastole of more than 7 centimeter. What are the associated complications? Does this patient regularly admitted because of the acute heart failure presenting with acute pulmonary edema? Or there is totally no symptom for the past 6 months or 1 year prior to the non-cardiac surgery. All this information is important when we're managing this patient in our operating theatre. The aim is to ensure that our anesthetic technique should provide optimum end organ perfusion, because a failing heart without the support will not be able to support the end organ perfusion, and we might end up with multiple end organ damage. Similarly, for the right heart failure, right heart is more tolerant to the volume, but is not tolerant to pressure. It is triangular in shape, it is non-dominant, but it is also associated with a significant morbidity and mortality after non-cardiac surgery. We need to understand the etiology of the right heart failure as well. Is there associated pulmonary hypertension, or is it because of the intrinsic factor of the myocardium that lead to the right heart failure? How bad is the failure? We can quantify this by understanding the echocardiographic parameter, understanding the TAPC measurement, understanding the dimension of the size of the right ventricle, understanding the thickness of the wall, and understanding how bad is the tricuspid regurgitation if it is present. Complication of right heart failure will be including but not limited to liver dysfunction and bilateral severe ankle edema or even ascites. So how do we manage this intraoperatively? Again, we need to maintain an optimum coronary perfusion, and as far as possible, try to avoid pulmonary hypertension. When we talk about pulmonary hypertension here, the pulmonary pressure should be less than 2/3 systemic. Now, let us understand the valvular heart disease. It is recommended that for us to understand the valvular heart disease, we should look into the echocardiography. If there is no prior echocardiogram being done within 1 year, or if there is any significant change in the clinical status or examination since the last evaluation, we definitely need a new echocardiography. We need to understand the lesion, and I will try to explain this in my subsequent slide. Intervention for correction of valvular heart disease is effective in reducing the perioperative risk in adults who meet standard indication for valve replacement or repair based on symptoms and severity of stenosis or regurgitation. Unfortunately, if this patient presented to us in an emergency situation, then we need to manage this patient by understanding the type and the severity of the valvular heart disease and devise our anesthetic approach using perioperative invasive monitoring to aim the hemodynamic goal depending on the lesions we are facing. Let us go to the first one, which is aortic stenosis. Aortic stenosis is the condition, the valve condition, the valve disease that has the highest risk of morbidity and mortality if this patient undergoing non-cardiac surgery. What is aortic stenosis? Aortic stenosis is when there is any restriction in the opening of the aortic valve during systole. We need to understand the severity of the aortic stenosis, okay, by looking into the size of the aortic valve area. Moderate aortic stenosis is defined by aortic valve area of 1 to 1.5 centimeters squared, whereas severe aortic stenosis is defined when the aortic valve area is less than 1. In this condition, the left ventricle is facing high pressure load. It is pumping against an obstruction. The cardiac output is fixed, resulting in severe left ventricular hypertrophy and high left ventricular end diastolic pressure. So A, we need to understand the etiology. What caused the aortic stenosis? Is it degenerative? Is it congenital, bicuspid, for example? Or is it iatrogenic for intervention? We have nowadays a lot of transcatheter intervention that might cause problems and resulting in aortic valve issues. We need to understand how bad is the stenosis. This has been discussed just now. And we need to understand the complication of the severity of the aortic stenosis. The more thickened the left ventricular wall, the higher chances that this patient might end up with myocardial infarction if we did not take care of the hemodynamic goals when we delivering our anesthetic to conduct the surgical procedure. If we have TEE, that will definitely assist us in getting us to optimize the hemodynamic condition. We have to aim for optimum cardiac output. We have to make sure that the coronary perfusion is optimized, especially during diastole. And you have to make sure that the cardiac output delivered by the left ventricle is enough for the end organ perfusion. If the surgery is not urgent, we might want to discuss with our cardiologists whether preoperative aortic balloon dilatation is suitable or not. In some situation, in some surgical situation, TAVI, transcatheter aortic valve replacement might be needed before the non-cardiac surgery. The next valve lesion is a mitral stenosis. Again, we need to understand the etiology of the mitral stenosis. Majority mitral stenosis is because of rheumatic heart disease. We need to understand how bad is the mitral stenosis. Moderate mitral stenosis is defined when the mitral valve area is anywhere between 1 to 1.5 centimeters squared. Severe mitral stenosis is when the mitral valve area is less than 1 centimeter squared. Again, this is a pressure load condition resulting in hugely dilated left atrium, making the preload to the left ventricle rather than fixed and resulting in the fixed cardiac output as well. Pulmonary hypertension is common. It is associated with high mortality and morbidity. In asymptomatic patient, non-cardiac surgery requires appropriate intraoperative and postoperative hemodynamic monitoring, which might include pulmonary artery catheter to monitor the pulmonary hypertension, and if available, transesophageal echocardiography. If patient is symptomatic, we might want to consider mitral valve replacement or repair earlier. But in the emergency situation, the anesthesiologist then have to ensure the optimum cardiac output and good end organ perfusion. We have to make sure that we can prevent acute pulmonary edema and prevent right ventricular failure. The third one is aortic regurgitation. It is more tolerable as far as non-cardiac surgery is concerned. But again, we need to understand the etiology, whether this is acquired or congenital, or whether this is degenerative. How bad is the aortic regurgitation? Again, it is defined by the regurgitation orifice area. Moderate AR is defined when the ROA is anywhere between 0.1 to 0.29. Severe AR is defined when the ROA is more than 0.3 centimeters squared. In comparison to the stenosis, regurgitation is a volume overload condition. It is usually associated with dilated left ventricle. Asymptomatic severe AR and having a normal ejection fraction undergoing non-cardiac surgery should have appropriate intraoperative and postoperative hemodynamic monitoring. And when we manage this patient, we should avoid high SVR to maintain good cardiac output. The fourth one, mitral regurgitation. Again, we need to understand the etiology. What caused the mitral regurgitation? Rheumatic heart disease is, again, one of the commonest cause of mitral regurgitation. Ischemic mitral regurgitation has its different risk altogether. Degenerative lesion, which include flail or prolapse leaflet, is quite common nowadays, even in the Asian population. Moderate MR is defined by the regurgitation orifice area of 0.2 to 0.39. Severe mitral regurgitation is when the regurgitation orifice area is more than 0.4 centimeters squared. Again, this is a volume overload condition. If patient is asymptomatic, severe MR with good ejection fraction, we can proceed with the non-cardiac surgery with appropriate intraoperative and postoperative hemodynamic monitoring. Our aim is to avoid high SVR, maintain cardiac output, and try to avoid acute pulmonary edema intraoperatively. The fifth condition is pulmonary hypertension. Pulmonary hypertension has a very high risk of morbidity and mortality after non-cardiac surgery. It could be primary pulmonary hypertension, or the pulmonary hypertension could be a secondary from any other form. This is of a concern, especially when the PA pressure is more than 2/3 systemic. It might be associated with certain degree of RV failure, dilatation, or dysfunction. And patient usually presented with poor New York Heart Association class. If you were to do non-cardiac surgery for this patient, you need to have a good hemodynamic monitoring, including PA catheter. You have to optimize the blood pressure, support the right ventricle, good oxygenation, and good CO2 manipulation to avoid unnecessary raise in the pulmonary hypertension. So the aim is to prevent systemic hypotension and to prevent acute elevation in pulmonary artery pressure. Those are the 5 commonest cases for adult coming to our operating theater going for non-cardiac surgery. But occasionally we do have congenital heart disease patient that coming for non-cardiac surgery. Congenital heart disease, again, is associated with high morbidity and mortality after non-cardiac surgery, especially if the condition is not corrected. Okay, so what are the commonest congenital heart disease that we might encounter? Number 1, post-Fontan procedure. In this case, we need to understand whether there is any obstruction to the fontan or not. And the management of ventilation is important for us to ensure good flow of the fontan. Number 2, severe pulmonary artery hypertension due to various causes. And the management of the pulmonary arterial hypertension is similar with the one that I have mentioned for the adult patient. Uncorrected cyanotic congenital heart disease. Okay. We need to understand what is the etiology, how bad is the situation, what are the complications associated with this uncorrected cyanotic heart disease. Or patient also might have a corrected lesion, but with some form of residual or complication, such as heart failure, valve disease, or arrhythmia. So in principle, when we are dealing with this kind of group of patients, we have to understand whether the lesion is causing the ventricle volume issue or is causing the ventricle pressure issue. And we need to manage this accordingly. I hope I have managed to run through as an overview to common cardiac condition coming for non-cardiac surgery. And I hope this sharing will then provide you with some guidelines on how to do and how to manage this group of patients coming for non-cardiac surgery. I think I will end my presentation here, and I will pass the podium to Dr. Kanchi for his subsequent lecture. Without further ado, Dr. Kanchi, the podium is yours.
Good afternoon, everybody. I'm indeed delighted to be a part of this webinar on cardiac patient for non-cardiac surgery. In the next 20 minutes, I'll be dealing with an algorithmic approach for a patient with cardiac disease coming for non-cardiac surgery. I'll just give a couple of, actually 5 case scenarios, which would make us think, what should we do? What can I do? Patient coming for elective cholecystectomy in a patient with ischemic heart disease. Patient with obstructed inguinal hernia in a patient with chest pain. Patient with lung carcinoma for bronchoscopy and thoracotomy in a patient who has a drug-eluting stent placed 3 months ago. Patient who needs a prostatectomy after having undergone coronary artery bypass grafting 2 years ago, or a patient with descending thoracic aortic aneurysm with ischemic heart disease, decreased left ventricular ejection fraction, and chronic kidney disease. So when we deal with such patients, we need to know, why should we worry about cardiac disease? And what is the pathophysiology of ischemic heart disease? How do we define myocardial injury in non-cardiac surgery and acute myocardial infarction? What should be our approach to a patient with cardiac disease coming for non-cardiac surgery? How do you risk stratify these patients? What should we monitor in these patients? How do you manage perioperative MI if it occurs in the theater or post-operatively? And what are the strategies for the cases highlighted in the first slide? And ultimately, I will end with the announcement of the International IACTA TE webinar, and I request you to join that. Coming to the first part, why do we worry about cardiac disease? This job has been, this fact has been highlighted by Dr. Suhaini very well. 1 in every 3 or 4 patients above the age of 45 years will have cardiovascular disease in the coming future. So cardiovascular disease is a leading cause of death in both developed and developing nations of the world. It's a true global epidemic. And this picture shows the statistics from the National Commission for Macroeconomics and Health in India. And on the vertical axis, we have the number of coronary heart disease cases mentioned in 100,000s. And we have on the horizontal axis, the year 2000, 2005, 2010, and 2015. And as you see, the coronary heart disease incidence has grown up in the last 2 decades. And what is more worrying is that in the age group between 20 to 30, that is the bottom white column, this population is also growing, which means that even if a patient is young, he might be suffering from coronary heart disease, which implicates that the chest pain in an younger individual should not be ignored, and it should be investigated for the possible associated ischemic heart disease or coronary heart disease. Coming to a couple of physiological principles, we should know that the heart is supplied by blood during diastolic phase. This is the systole, this is the diastole, and the blood flow to the coronaries occurs as a result of coronary perfusion pressure, which is the difference between the aortic diastolic pressure and the left ventricular end-diastolic pressure. And the second point we need to remember is, what are the factors which influence the myocardial oxygen supply and demand? The myocardial oxygen supply is determined by the oxygen arterial content, which in turn depends upon the hemoglobin concentration, the saturation of arterial blood, and the position of oxygen dissociation curve, and how good is the coronary artery blood flow in terms of coronary perfusion pressure and the absence of coronary artery disease. On the demand side, we need to control the preload, afterload, contractility, and the heart rate. These are the factors which determine the myocardial oxygen supply demand. This is a physiological principle. Coming to the definition of myocardial injury and myocardial infarction, myocardial injury is just defined as elevated cardiac troponin values with at least one value above 99th percentile of the upper reference limit. And this myocardial injury is expected to occur in about 8% of patients above the age of 45 when they are undergoing major non-cardiac surgery. And this is a determinant of the outcome in terms of mortality and morbidity. Coming to the definition of acute myocardial infarction, acute myocardial infarction is defined as a condition where there is clinical evidence of rise or fall in cardiac troponin values with at least one value above 99th percentile of the upper reference limit when it is associated with one of the following clinical conditions, that is the patient complain of chest pain, or there are new ECG changes in terms of ST segment elevation or depression, or development of new pathological Q waves, or you have demonstrated regional wall motion abnormality by imaging techniques such as echocardiography, or you have demonstrated a coronary thrombus by angiography or at autopsy. So there are 5 different types of myocardial infarction which have been described. We will be dealing with type 1 and type 2 because this is what we are interested. Type 1 infarction is a infarction which occurs in a patient who has a stable coronary artery disease, but this patient has been exposed to abnormal stresses during the surgical procedure or preoperatively or perioperatively, which leads to the plaque rupture and accumulation of platelets, the acute obstruction to the coronary artery, leading to acute myocardial infarction. This is the typical myocardial infarction. The second type of myocardial infarction is the one where there may not be any coronary artery disease, but just because of the heart rate has gone up or the blood pressure has gone down during the anesthetic management or surgical management, there is a acute imbalance in the oxygen supply demand, which predisposes the myocardium to myocardial infarction. If it is not treated promptly, it will lead to myocardial necrosis. So the myocardial injury after non-cardiac surgery is an elevation of postoperative troponin, which has an ischemic origin without other criteria of perioperative myocardial infarction, and this is prognostically relevant. Now coming to the, how do you approach these patients who have cardiac disease undergoing non-cardiac surgery? This is described in this 7-step approach to the perioperative cardiac risk assessment in patients undergoing non-cardiac surgery. This has been published in American College of Cardiology and AHA guidelines in 2014, and this probably is one of the best approaches which we can count upon. And this I have expanded into 2 different slides just for clarity. In the step 1, we need to determine, this was actually pointed out by Dato, Dr. Suhaini as well. First step, we need to know whether the surgery is emergent or it is elective. If it is emergent, the patients need to go to the theater straight away, and no further cardiac evaluation may be possible. And the patient, as he is undergoing the surgical procedure, the anesthesia has to be tailor-made to the requirement of the patient, which includes appropriate monitoring and estimation of blood levels of troponin and other parameters which need to be looked into. Here, we don't have time to prepare the patient for surgery because the patient needs to undergo surgery straight away because the surgery is limb-saving or life-saving. If it is not emergent, that is elective surgery, if it is elective surgery, we need to go to the step 2, where we need to see whether the patient has any active cardiac conditions. If the patient has any active cardiac conditions, patient needs to be evaluated, patient needs to be referred to the cardiology department, and further management is to be done so that you optimize the patient's condition before the patient is actually subjected to the non-cardiac surgery. If there are no active condition, we need to look into the estimation of perioperative risk and also look at the risk of major adverse cardiac events, which I will delineate in the next couple of slides. There are two major risk scoring systems available with us. I will delineate that in the next couple of slides. And if the patient comes under low risk category in the step 4, patient can undergo the non-cardiac surgery without any further evaluation. But if the patient has elevated risk, we need to look into the problem little more carefully. If the patient is having elevated risk, that is the risk of more than 1% mortality based on the risk scoring, which I will be dealing in the next 2 slides, in which case we need to look into the functional capacity. If the functional capacity is excellent, which means that the METs, that is metabolic equivalents, are greater than 10, or good, that means the metabolic equivalents are greater than, between 7 to 10, or poor, we have to determine if the METs are more than 4, no further testing is necessary for the sake of giving anesthesia and proceeding with the surgery. But the metabolic equivalents are less than 4, or the metabolic equivalents cannot be determined. For example, patient is having immobility because of certain pathological conditions such as knee disease or hip disease, in which case we need to go to the step 4, and we need to subject the patient to pharmacological stress testing. And if the tests demonstrate significant abnormality, we need to study the patient little more extensively, especially in terms of coronary angiography or any other suitable investigation. But if these tests of pharmacological nature reveal normality, patient can undergo surgery straight away. Coming to the risk scoring, the two common methods are, one is the revised cardiac risk index, which includes 6 predictors: history of ischemic heart disease, history of congestive heart failure, history of cerebrovascular disease, history of diabetes needing preoperative insulin, history of kidney disease with creatinine more than 2 milligrams per deciliter, or the surgical predictor is the suprainguinal vascular, intraperitoneal, or intrathoracic surgery. If you add up all the risks depending upon the presence or absence, and if the predictors are 0, the expected risk of death or the major adverse cardiac events is 0.4. If there are 1 predictor, it is 0.9%. If there are 2 predictors, it is 6.6%. If there are more than 3 predictors, it is 11%. And also you can classify the surgical risk into low risk category or high risk category. If it is 0 to 1 predictor, it is low risk. If it is 2 predictors or more than 2 predictors, it is high risk. And please note that the recent guidelines have removed that intermediate risk category, because the management of intermediate and high elevated risk or high risk is similar. So we need to look into either it's a low risk case, low risk procedure, or high risk procedure. This is the National Surgical Quality Improvement Program, which is a calculator which is based on data derived from more than 1 million surgeries, provides more comprehensive assessment of surgical risk. But it's a little more complex, and it is web-based, and this can be used, being used in North American continent. And this paper highlights that when we assess the functional capacity, it is better to use the Duke Activity Status Index questionnaire, which is a little more accurate as compared to just going by the subjective assessment of the functional capacity by interviewing the patient. This is the Duke Activity Status Index. And the another index which has been highlighted in the recent, I mean, not exactly recent, in the last 10 years is the Gupta Myocardial Infarction Cardiac Arrest Index, which is used to estimate the risk of myocardial infarction or cardiac arrest. It includes high-risk patients who have been managed with current medical practices and surgical techniques. It includes 5 parameters. What is the type of surgery? What is the functional status? Is the renal function abnormal? What is the ASA class? And what is the age of the patient? Depending on that, this risk score has been found to have better discriminative ability and predictive accuracy as compared to the least revised cardiac risk index. And the role of biomarker has been highlighted in the Canadian Society, Cardiovascular Society recommendations. And this has been highlighted by Dr. Dato, Dr. Suhaini. So I'll skip on this. And a practical approach has been designed in patients for preoperative risk stratification. If you have a high-risk patient with RCRI, that is revised cardiac risk index of greater than 2, we might opt to do the biomarkers. And if the biomarkers are normal, that is cardiac troponin less than 0.014 nanograms per ml or the BNP less than 20 picograms per ml, patient can undergo surgery straight away. But if it is elevated, we need to look into the ventricular function by using echocardiography and cardiology consultation and the medical therapy optimization, and probably delay the operation until the troponin levels have come down to the normal. In the 2019 Journal of Cardiothoracic Vascular Anesthesia, we have suggested few modifications of the approach to non-cardiac surgery in cardiac patients, because cardiovascular disease is very rampant in Southern Asian countries, and bedside echocardiographic examination using handheld or portable ultrasound device is available in most of the major cardiac centers. And the idea is that we get baseline information and it may be useful in medical legal purposes. So what we have suggested is that in the step 1, we have suggested that before the emergency surgery is done in a patient with cardiac disease undergoing non-cardiac surgery needs emergency surgery, we should consider bedside ECG, chest X-ray, and echocardiography, which can be done fairly quickly. We do not need a detailed echocardiography report, but the valvular function, the ventricular function, and probably pulmonary artery pressure estimation in a quick manner, which can be done within 5 to 10 minutes with transthoracic echocardiography, and then subjecting the patient to the emergency surgery may be advocated, because we have the baseline information, and then we can titrate the anesthetic management as per the needs of a given particular patient. And we also suggested that when we are progressing to step 2, the ECG, X-ray, and detailed echocardiography and review of drug history may be included. And in these progression from step 5 to step 6, we have suggested that include biomarkers to decide whether pharmacological or stress testing is needed. And the fourth suggestion we have made is that instead of pharmacological stress testing, we may use a coronary angiograph using CT scan. That is, the CT coronary angiogram can be done to determine if the patient has significant coronary artery disease. And if needed, then you can subject the patient to the traditional coronary angiography. These are the modifications we have recommended. This is we are looking forward to your comments on this. And coming to advanced monitoring, we may use a Swan-Ganz catheter or the transesophageal echocardiography in high-risk patients undergoing major surgical procedures which are of non-cardiac in nature. So what we have done is we have developed an algorithm for the choice of hemodynamic monitoring depending on what is the risk based on the revised cardiac risk index, what is the functional status, what is the left ventricular function, and as I said, the risk, is it a low risk or elevated risk? Depending upon the ventricular function, and the risk and the monitoring device can be tailor-made to a particular disease, surgical procedure using this algorithm. And for example, if the patient is ejection fraction is 40 to 50, and the patient is undergoing elevated risk surgery, we have advocated use of direct arterial pressure, central venous pressure, along with a non-invasive cardiac output monitor such as flow track. But if the patient's ejection fraction is less than 30%, this should read 30%, less than 30%, undergoing elevated risk surgery, we have suggested advanced cardiovascular monitoring in the form of pulmonary artery catheter and echocardiography. Coming to the anesthetic considerations, use of volatile anesthetic agent or total intravenous anesthesia is reasonable for patients undergoing non-cardiac surgery. Neuroaxial anesthesia for postoperative pain relief may be effective to reduce perioperative MI in patients undergoing abdominal aortic surgery or thoracic surgery. Prophylactic intravenous nitroglycerin is not effective in reducing myocardial ischemia, but we need to monitor the patients carefully, and at the first sign of myocardial ischemia, we need to intervene and start intravenous nitroglycerin. Intraoperative monitoring techniques, the perioperative TE may be resorted to if there's a hemodynamic instability, which is not responding very quickly to the usual maneuvers. Maintenance of normotherapy is advocated. Hemodynamic assist device may be considered if the patient has acute severe cardiac dysfunction. Perioperative use of pulmonary artery catheters may be considered depending upon the underlying medical condition. Coming to the cases we have highlighted, patients who need, this is a flow chart to look into the approach. Patient with ischemic heart disease needs elective cholecystectomy. We need to look into this is elective surgery. So we have skipped the first patient probably has stable ischemic heart disease. First two steps of the approach are skipped, and we determine the risk. And if this becomes high risk because of the intracavitary surgery, patient needs open cholecystectomy and intracavitary surgery with ischemic heart disease. That means the RCRI is greater than 2. And we look at the functional status. If the functional status is less than 4, we need to do the stress test. And if there's significant coronary artery disease in terms of critical triple vessel disease or left main disease, we might have to consider cardiac surgery before subjecting this patient to non-cardiac surgery. Coming to the second case scenario, this is emergency. So it is in the first step and it is life-saving, and we need to subject the patient to the non-cardiac surgery. And because patient is having ongoing chest pain, we might also consider whether we can do a off-pump coronary artery bypass grafting in the same sitting. If you are in a good cardiac center, we might have to consider this, or you have to probably, if you are in a smaller center, you might have to refer this case to a center where there is a facility for cardiac support, both in terms of cardiology and cardiac surgery. The third case scenario, the lung carcinoma with drug-eluting stent. Drug-eluting stent has been placed within 3 months, and the patient has to undergo surgery because we cannot wait any longer. The recommended duration of antiplatelet therapy, mandatory therapy, is 180 days, but this is a sort of semi-emergency. So we need to have a multidisciplinary approach involving the cardiology, anesthesia, intensive care surgeons viewpoint, and the patient preference all have to be undertaken. And the options mentioned here are we need to because we need to take the patient without any further delay in terms of within a few days we need to do the surgical procedure. We need to, the options available here is the bridge therapy with pyrophebine or cangrelor, or you estimate the percentage of inhibition, or you take the patient with platelets available. And the point I would like to make here is that the platelet transfusion before surgery prophylactically is not indicated. And if the patient bleeds on table, then we could resort to platelet transfusion, which means that we need to have platelets available when we are taking such patients. Coming to the fourth case scenario, patient undergone CABG 2 years back, prostatectomy, is a stable patient, and meds are more than 4. So the regional technique comes in handy here as long as you have taken care of the antiplatelet medications. And the last case scenario is patient with descending thoracic aortic aneurysm with ischemic heart disease, reduced ejection fraction, chronic disease, kidney disease. Patient should preferably go for endovascular stenting rather than a open procedure. Coming to the last bit of my presentation is what do you do if the patient has a perioperative myocardial infarction in the operating room or just after the cardiac surgery? Just after the non-cardiac surgery. Patient has undergone major non-cardiac surgery and patient landed with a perioperative myocardial infarction. This can happen and there's a lot of confusion what to do. So this is a ready-made diagram to think about quickly what to do in such a situation. The treatment should be individualized depending upon the patient's age, comorbidity, and the life expectancy. If the patient is more than 75 years and a lot of comorbidities and life expectancy is within 6 months, we need not have to be very aggressive. We also have to consider, is the patient stable or unstable? And what is the nature of myocardial infarction? And also whether the patient has a high risk of bleeding. So the risk of bleeding can be determined by looking at the Crusade and Gray score, the Crusade score, which categorizes the patients into low risk, intermediate risk, and high risk of bleeding. Depending on that, we need to make a decision whether you are going to do the conservative medical management or a high invasive early invasive strategy in terms of percutaneous coronary intervention. So the cardiologist must be involved at this stage, and we determine whether the ST segment elevation MI and the bleeding risk. If it is ST elevation MI, possibly we should go in favor of the invasive strategy. If it is non-ST segment elevation MI, we should consider conservative management. The conclusions are here. The cardiovascular disease is rampant, as pointed out by Dr. Suhaini, and I will also reiterate that factor. We are going to see every third or fourth patient coming for non-cardiac surgery with cardiovascular disease, and this number is likely to increase in the coming years. Management of cardiac patients undergoing non-cardiac surgery requires in-depth understanding of the cardiovascular pathophysiology and interaction of the surgical and preoperative risk factors. What is the functional status of the patient? That is a crucial factor that determines the need for extensive perioperative workup from cardiological point of view. And we need to understand that the patient may not be having ischemic heart disease in terms of coronary stenosis, but may still have acute myocardial infarction if there is extremes of tachycardia or hypotension during surgical management under our care. Whether it is induced by anesthesiologist or surgeon, that's a different matter. But if the patient has a precarious condition, the patient may develop acute myocardial infarction despite the fact that patient does not suffer from coronary artery disease. This I would like to reiterate. Perioperative optimization of myocardial oxygen demand supply balance is absolutely imperative, and we should have a strategy to diagnose and manage perioperative myocardial infarction in case the patient develops a perioperative myocardial infarction. Before I conclude, I would like to announce and request you to join for this meeting coming up next weekend. This is the 15th National 6th International Teaching Virtual Workshop from CTE. Dates are 20th, 21st, 22nd August. There are about 100 eminent experts from across the globe will be interacting. And there are interesting features like golden plate contest where young researchers will be presenting their papers. And these are the links for you to register. With this announcement, I would like to end my talk, and I would like to thank you for your patient hearing. And we are looking forward to looking at the chat box to answer any questions. I hand over the podium to Dr. Dato Suhaini to moderate the question answer session.
Yeah. Okay, Dato. Yes, you may proceed with the Q&A sessions. We have a question here that when we stratify risk of MACE for patients, the type of surgery, for example, major op, intermediate op versus minor op, from how I understand, major op is more than 5% death. So his patient RCRI is 1, but going for major op is more than 1% of MACE, or do we solely use RCRI to estimate the MACE?
I think this question is directed to me. Can you repeat the question? I didn't quite follow the question.
Okay. When we stratify the patients for MACE, the type of surgery, for example, major op, intermediate op versus minor op, from how I understand, major op is more than 5% mortality.
Yes.
Yeah, if the patient is RCRI is 1, but going for major op, if this is a more than 1% MACE, or do we solely use the RCRI to estimate the MACE? Thank you.
If the risk is 0 to 1, it is considered low risk. And if it is 2 or more, it is considered as elevated risk. And any procedure above the inguinal ligament, which is vascular in nature, or it is intracavitary, it means the intra-abdominal, intrathoracic, cardiac, or even intracranial. If it is intracardiac, that qualifies to be a risk predictor, and that will get 1 point. That would be my response. If it is only 1 point, it will be still, if the patient does not have ischemic heart disease, does not have diabetes, no cerebrovascular accident, no diabetes mellitus, no history of congestive heart failure, that patient will be considered as low risk from cardiovascular point. He does not have cardiac disease. Basically, there's no history of cardiovascular disease, no history of congestive heart failure, no cerebrovascular disease, no renal disease, no diabetes, but undergoing suprainguinal intracavitary surgery, that will be classified as low risk. And we don't need any further investigation for that. As far as the approach which has been delineated in 2014 guidelines, which is followed worldwide.
Okay. Any add-on from Dato? Any opinion?
Not from my side. I'm okay with the answer provided by Dr. Kanchi.
Thank you.
Well said.
Thank you.
I have a couple of questions that we've been posed earlier. Sorry that we run over time a little bit. Just maybe we pick up one or two questions. Yeah. For the audience, if you have any burning question, you may raise your hand and speak out. While waiting for that, Dato and Prof, I would like to ask a question: is what is the opinion on the role of spinal anesthesia in patient with IHT with EF of less than 30%?
Is this question directed to me?
Maybe Dr. Kanchi can answer that question. Yes.
Yeah, you can add your viewpoint just after mine. Role of spinal anesthesia in patient with ischemic heart disease, ejection fraction less than 30%. Depends upon what is the nature of surgery. Is it lower limb surgery or is it prostatic surgery? In which case, we could institute spinal anesthesia with monitoring. I would recommend that the the intra-arterial blood pressure and central venous access is obtained, and the spinal anesthesia can be provided for lower limb surgery and pelvic surgery. That will be my answer, but the patient should be under full monitor conditions, and the patient is optimized for the surgical procedure. And Dato, you want to say something for this?
Yeah, for regional anesthesia, I mean, the issue of regional anesthesia is actually reduced SVR. So we have dilated peripheral vessels because of the spinal or regional anesthesia. And therefore, the blood pressure might be compromised. So it depends on the technique of regional that you are implementing. If you can gradually reduce the SVR under a proper control without affecting the sudden drop in the blood pressure. Okay, the drop in blood pressure here is basically to maintain diastolic perfusion to the coronary. That is the aim. So if you have a starting blood pressure of 200 systole and 90 diastole, you deliver your original pressure drop to 150 to 85, that is okay for me, no issue. But if you start with a blood pressure of 200 over 95, you start your original, the BP drops to 100 over 45, that might cause an issue because you compromise the diastolic perfusion of the left ventricle. You need to address the sudden drop in the SVR. Okay, how do you address that? Sometimes the vasoconstrictor that we use overshoot. When you deliver the vasoconstrictor and the blood pressure overshoot, you cause unnecessary sudden increase in the SVR afterload and stressing the heart further. So it's all about technique. There's no right and wrong answer here. It's how you address each particular problem delicately and understanding the underlying condition of your patient. So if this is a less than 30% ejection fraction, but the coronary are good, okay, it's maybe because of the dilated cardiomyopathy, and patient is going for hernia surgery, for example, and you can deliver the original in a gradual manner without affecting much of the blood pressure, go ahead. There's no major issue of that. But if the patient is ejection fraction of less than 30%, left main stem is significantly compromised, block, 95% block, for example, or more than 95% block. Okay, and this is clearly an ischemic cardiomyopathy. LV dimension is big, 7.5 centimeter. Patient is going to go for some vascular surgery, and you want to implement regional, be careful. You might need extra hemodynamic monitoring to carefully manage the hemodynamic condition, because the left main stem there might then lead you to a perioperative myocardial infarction. So there's no straight right and wrong answer, but it depends on the patient's situation and it depends on how you deliver your anesthesia technique.
Absolutely.
I hope
Yes. I agree with that. And when I mentioned spinal, it is a patient is sitting and you give the spinal. Patient is not in the lateral position when you give the spinal. Patient is sitting and you give the lowest possible dose for that particular patient so that there is no spread causing sympathetic blockade when it goes to the upper segment. So if you avoid that and cause only the lower part of the motor and sensory blockade, that should suffice. For lower limb surgery, I'm talking about lower limb surgery.
Yeah. All right. So one question in the chat. Yes, sorry.
And in patients who have regurgitant lesions, decrease in systemic vascular resistance may be therapeutically beneficial. So we have to consider that. And because we don't want to decrease the blood pressure suddenly, epidural is a better choice. The graded epidural may be a better choice.
Okay. So I have a question in the chat saying that what are the opinion on role of medication in pre-op optimization, i.e. beta blocker, ACE inhibitor, dual platelet statins? What is your opinion?
Very nice question. Shall I answer that?
Please, Dr. Kanchi, please.
When you're talking about beta blockers, if the patient is on beta blockers chronically, it must be continued. There is no second doubt about it. If the patient is already on beta blockers, he or she must receive the beta blocker continued till the surgery, including a dose in the morning. But if the patient is not on a beta blocker, but is a high risk category for cardiovascular disease, The beta blocker can be initiated anywhere from 1 to 7 days before surgery. The third point is that the beta blockers cannot be started within 24 hours of surgery. These are the American Society of Anesthesiology recommendations, because we do not know the response of the patient to given beta blocker, and the risk of hypotension cannot be assessed by just starting the beta blocker within 24 hours of surgery. So this is my response to this question.
I am totally agree with you, Dr. Kanchi.
Thank
There
you.
is no supporting evidence to start immediate perioperative period with a beta blocker, ACE inhibitor, alpha-2 agonist that has been elaborated in fairly lengthy in the recent Canadian review on the management of cardiac patient undergoing non-cardiac surgery. In fact, the risk of complication and morbidity is higher if you were to start beta blocker or alpha-2 agonist immediately before the perioperative period.
Absolutely. Yeah.
Okay. I have one last question here in view of respect everybody's time. If a patient has a recent CABG, what is the best timing for an elective surgery? How about stroke?
If the
And
patient has a recent CABG,
yes.
my answer is that we need to wait at least 6 weeks to be able to see that the endothelium is formed well at the place of anastomosis. And then we also have to consider the anticoagulant status of the patient, and then subject the patient to surgery.
Thank you. Dato, any comments on your end?
Yeah, it's always good for us to have a good communication with the cardiothoracic surgeon as well. So we can have direct communication with the surgeons involved, and he might be able to assist us in providing extra information following scheduling a patient immediately after CABG to a non-cardiac surgery. Things like complication that might arise after CABG should be high in the list. Common complication are, for example, what do you call it, cerebral complication, renal complication, or even the list of new medication that is being provided to the patient need to be considered before we decide for a non-cardiac surgery in the immediate post-CABG period. So communication is the keyword.
I agree. I agree. And also, when I mentioned 6 weeks, the patient must be absolutely stable in terms of cardiovascular condition, and he has fully recovered from the effects of the surgery. That should be highlighted.
What about stroke, post-stroke? Slightly additions.
Patient had a stroke and he needs to undergo non-cardiac surgery. Very interesting question. The recent guidelines recommend that you need to wait for as much as 6 to 9 months for the cerebral autoregulation to get back to the normal, and the reactivity of the cerebral vasculature for carbon dioxide changes to come back to the normal situation. That is the time recommended, but it also depends upon the gravity of the non-cardiac surgery which you would like to do, whether it's urgent or semi-urgent or it's elective.
All right. Okay.
Would you like to add to this, Dr. Dato Suheni?
Yeah, totally agree with you, Dr. Kanchi. My approach will be again ABC. What is the etiology of the stroke? Is it thromboembolic? Is it hemorrhagic? We need to understand this. And how bad is the the so-called the cerebrovascular accident? Which area involved, and what does the stroke complicates the overall other end organ of that particular patient, and what are the patient's medication on? All this will have to be played in a considerable manner for us to decide for the subsequent non-cardiac surgery or any other surgery for patient post-stroke.
Thank you very much.
Your formula of ABC is wonderful. We can apply to any condition, looks like.
Yes, yes, indeed. It is very
Airway
easy to
breathing
understand.
circulation.
Yeah,
Just like airway breathing circulation. Very nice.
good.
Thank you.
All right.
Thank you, Dr. Kanchi.
Yeah. I think it's very, very enlightening afternoon that we have from Dr. Suhaini and Professor Kanji. And thank you very much for your excellent sharing. Yeah, I know we are just over time as we kicking off the introductory sessions as of today. I encourage everyone here to sign up for the program to continuous learning from us. And we look forward to chat and learn with you in the coming months. So finally, thank you all for your time joining us in this afternoon sessions. As you look into that, you in the chat box, there are two links there where you can click on it, and one is on the feedback. We honored your appreciate your feedback to us, what we do well today and what area for improvement. In addition to that, there's a click box for you to sign up for the program. And in addition, we also will email the recorded webinar to you within next week. Thank you very much, and we look forward to see you again in October. Thank you very much to our panel faculty, Dr. Suhaini and Professor Dr. Kanchi. Thank you. Bye-bye.
Thank you so much. Thank you. See you again sometime.
See you again. Bye.
Thank you so much.